Well, thank you for having me. I'm very excited to be here and speak on behalf of VA this morning about what we're doing in the innovation sphere. And in fact, that word is somewhat nebulous. What does it mean, innovation? And I'm still trying to figure it out, but as the innovation fellow, I'm studying fast and trying to really understand. And what I'm going to talk to you about today is an example of one of the innovations that we're working on with specifically in healthcare, and that is 3D printing. But in order to do that, I want to take a step back first and look at another technological innovation that happened about 100 years ago and use that as a starting point for our discussion today. So I don't know how many people have seen this image before. I'm a radiologist, so this is a favorite image of mine. This is the hand of Mrs. Anna Rankin. She's the wife of Sir Conrad Wilhelm Rankin, who is the father of X-rays. And he was a German engineer. He was a physicist. Notably, he's not a doctor. And he was working for years to discover X-rays, and when he finally got it working, as any of us would, he, started X-raying everything, all the things in his house, inanimate objects, etc. And I'm not sure exactly how it goes, but I like to imagine that Anna kind of came in to see what he was doing, and he probably grabbed her and was like, "Come over here, put your hand down here, let's see what we can do." And I think it was really spontaneous, but he happened to take this image of her hand. She wasn't really thrilled about it when she saw it. You can imagine it was probably very creepy, and she actually said, "I've seen my own death," when she looked at this, which is sort of evocative. But it was really serendipitous because this image not only captured her imagination and evoked this strong response, but when it was shown to the public, it captured the imagination of so many people. The really important thing about this is this was not a medical innovation. This had nothing to do with medicine. Again, he just happened to take Anna's hand. So he was not thinking about that. But this is the difference for me between invention and innovation. He invented X-rays. Then he put that out into the public, and the public, all of us, well, back in the time, looked at that and thought about how could that solve problems we have. And it's no secret that this went on to become a big deal for medicine. This is a technology that's revolutionized the field. There's an estimated 3.6 billion diagnostic X-rays performed annually. And that's just the start, because all of imaging kind of evolved from this. So 3D printing. This is another engineering tech invention that was not made specifically for medicine. But we're sort of hijacking it and looking at it and thinking about it. And so this is an actual person's brain. Now, not the right size. Don't worry. It's been shrunk down in this particular instance. But this is a true representation down to the millimeter level of somebody's brain taken from a CT scan. And, being able to hold actual physical human anatomy, and especially if it's yours, imagine Anna, it might make you feel a little squeamish, right? But it may be that in another 10, 15 years, this is just as commonplace as X-ray. This is Chuck Hull. He is the inventor of 3D printing. For those of you who are not familiar with it, which is probably not a lot at this point, but it's a technology that allows you to take digital blueprints and then create real three-dimensional objects from it. So I brought a few up here. This is one example. This is the bronchi, you can see. So this is a woman, she's in her 40s. Nothing wrong with her, luckily. This we just created just to be able to hold it. But so this started as two-dimensional CT layers, and it's become three-dimensional. You can see, if I'll pass it around later, it's hollow. You can, breathe into it. I don't think that would really do anything for us, but you could, right? So this is what we're talking about, right? And Mr. Hull, similar to Rankin was, fiddling in his, I imagine he was in his basement, probably, because that's where all great work happens, right, is in the basement. And he managed to 3D print something. And so he ran upstairs and he woke up his wife. Poor thing, she's sleeping, and you gotta come down here. So she had to come down in her pajamas, and she's kind of probably cranky, and she said, this better be good. So was it? Well, it's pretty good. Good enough to fuel a manufacturing technology estimated to exceed $20 billion in 2020, and impact fields as diverse as architecture, aeronautics, and medicine. But for us right now, what do we care about? It's medicine. And so within the VA healthcare system, we have 9 million veterans that we take care of every day, and we are very mission focused in terms of what that means. And that really means to provide the best care possible to each and every one of those patients. So when we have an opportunity to grab hold of a new technology, we want to do it. And we are doing that with 3D printing. And I am actually very proud to say that I think we are a leader, or I know we are a leader in this, because in 2010, there were about 3 hospitals in the country with 3D printing. Now, the estimated number is about 115, so it's pretty good. But within VA, we have at least 25 of those. And I know we're a big healthcare organization, but that is a disproportionate amount. And I think that speaks to our passion and devotion to moving things forward in the innovation space. So, but why? Okay, so I told you we have them, but why? Why is VA interested in 3D printing? And again, it gets back to that mission, trying to provide the best services possible to our patients. And again, remember, 3D printing was a non-medical tech revolution. It's been put out to the public. So we need to do the hard work of taking a hold of it and imagining what types of problems it could solve, and then going through, testing them out, seeing if they have merit and value, which would be the first piece of the innovation, see if they're feasible. You can have a great idea, but if you can't do it, it's not a great innovation, right? And then scaling it. So I'm going to show you a few of the ways that we've done this, but this is one of the most difficult problems for me, anyways, and I think a lot of us, and this is what we like to call the elephant in the room, which is communication, right? So this is a patient, a veteran from my home hospital in Seattle. He was born with 1 kidney. Of course, he had no idea about that. No one knew, or he wouldn't have been in the military, right? But you can do fine with 1 kidney, as long as that kidney's fine, right? Well, he developed, unfortunately, a tumor on that 1 kidney. Now, if we have 2 kidneys and you have a large tumor, it's okay. You could take out the 1 kidney, you still have the other kidney to function. But if you've got 1 kidney and 1 big tumor, you have a problem. You don't want to take out the whole kidney, because what will happen? You're going to be on dialysis for the rest of your life. So this kidney was a pelvic kidney. It means it didn't ascend to where it should be normally in the body. It was kind of sitting down here. It had all these abnormal vessels going to it. And his surgeon's a great surgeon. He was going to be able to scoop out that kidney, the part of the kidney that had the tumor, and leave it. But it was going to be challenging. And when we talk with patients and we want to take them into something that's challenging and difficult, we want to give proper informed consent. And that really means making sure the patient understands what the problem is, understands what their options are, and then decides for themselves whether they want to do it or not. But if we can't get them to understanding the problem, how can they make the choice? You know, it's like when I go to unfortunately, I didn't learn about cars, so when I go to get my oil change and they come out and they tell me, this is broken and that's broken, and are you lying? Is it true? Do you want money? I don't know. I have no idea. So it's an awkward situation. So I can deal with that, but you don't want that with your patient. And so this patient is saying here about his experience. When we try to show him, we draw pictures, we show them the images, but here he says, look at this. This is just a bunch of black and white gobbledygook that you're showing me on the screen. I have no idea what this means. It's a huge problem. This is his surgeon. This is Dr. Porter, a fantastic innovator and surgeon and good person who has a different problem, right? So he needs to go in and open up this patient and look in and say, okay, this is unique anatomy, it's different, but I have a job to do and I need to get a tumor out, right? So he's looked at all the images beforehand, but you can imagine it's a little different when you're looking at two-dimensional images and then you go in and look at the body. And so this is what he's told me. Sometimes I have to scrub out of a surgery multiple times so I can go to a computer and look at those images and figure out what's going on and then scrub back in. It's not ideal, right? So how might we solve these two problems with 3D printing? And this is what we've settled on over the past few years as we've worked out this problem with Dr. Porter, is we 3D print the patient's kidney. So that's the kidney there. It's in the operating room. But before it got to this point, they sat down together, the surgeon and the patient. He handed the patient the kidney. The patient was able to hold it up to himself, kind of size it in, understand. They were able to draw on it, and I'm going to show you here in a moment how he was able to draw on it with a Sharpie. But that patient then felt informed and capable of making that decision. And now we've got it in the operating room, and instead of scrubbing out, look, he just needs to turn around and take a peek. But it went further than that. Because not only can he see it, but he started to learn new things that he could use it for. So he's using it for depth cues. It's helping him to operate faster and safer and better. And then you kind of get the satisfaction at the end of seeing a job well done. So he was able to scoop out that tumor. You can see on there, there's the Sharpie line. We've gotten more advanced. We can print in multiple colors now, and we'll show you some of these things. But you know, a good old Sharpie might help sometimes. And so, job well done. That's one of the applications. But one of the other amazing things about both innovation and VA is that we have a strong focus on getting our innovations rapidly to the frontline staff. We don't want innovation coming from the top down because, again, remember, we have a new technology. We're exploring what could we do with this technology, and we need problems. And we need the people that understand the problems, who are the frontline staff. And I like this quote quite a lot. And this says, in the beginner's mind, there are many possibilities. And in the expert's mind, there are few. And so 3D printing in particular is at a beautiful point for innovation because it is new to a lot of us. You know, even if you know what it is, it's full of possibilities. And we haven't been kind of indoctrinated into thinking this is how you use it. When a tool becomes really obvious how you use it that way, like a fork, right? We use that to eat. But what if we didn't know what a fork was? What could we do with it? And so we are trying very deliberately to get 3D printers into as many VA hospitals as possible, into the hands of as many different types of staff as possible, to try to start unlocking these possibilities. And this is one of my favorites. So this is this is Mary Matthews Brownell. She is a licensed certified hand therapist. You're seeing her kind of peeking through her 3D printer. She is amazing at what she does. And so she sees patients who have chronic disabilities with their hands specifically. So you can see here on the left, this is a patient that has a contracture. Kind of this Benedictine contracture is the term for this. But the last two fingers here are permanently in this position. It makes it very hard to use a hand. And she's able to craft these hand braces that she builds like on the fly there to help fix that, to open that up. But it takes about an hour or so. They're made out of this molded thermoplastic. They break after 3 months or so, and the patients need these for years. So then they have to come back. And a lot of our patients are rural. So a lot of our patients live far away. So they might be driving 3 hours back and forth, you know, every 3 months. And what happens when it breaks, you know, and they're somewhere else, like abroad or not near a VA? And so she had the amazing idea of, once she makes a hand brace, why doesn't she just digitize it and then we could print it so the patient doesn't have to keep coming back? So every time it breaks, you could just hit, boom, print, send it out. Fantastic idea, and we started to do that. So that's actually a 3D printed hand brace there on the right. Then we started talking with our engineers, and they said, well, you know, look at all these seams. These seams, you know, are the break points. Why don't we just take them out? Because the technology allows us to do that. So we started taking the seams out. And then now we're thinking, okay, how do we use the abilities of the materials, the fact that we can print in multiple materials, or we can change the properties depending on how we lattice it to make it softer in some places and harder in other places. And so that's some of the work that she's doing now. This, let's see if I can make it play. Yes, so here's Dr. Porter again. This is the next iteration that he's come up with. And this is another kidney. So let's see if I can do a point. I don't know if I can. But up at the top, he's cut out this kidney's tumor here. And you can see it kind of has this crunchy look to it. So this tissue, and I use tissue in quotes because it is 3D printed material, but this material is designed to mimic the human tissue. And that's important for him to be able to cut on it and operate on it before he ever walks into the operating room to rehearse and get that feel. And so you normally don't see a surgeon operating without gloves, right, and in his suit. But he can do that here. And you know, he's an expert. He probably doesn't need that. But what about all of the future doctors, nurses, other healthcare professionals that are coming through the country? And VA is the #1 training site for our up-and-coming physicians. So how might we enable them to learn faster, learn from Dr. Porter, but also practice beforehand so that they're practicing on you, but the 3D printed you before they go into operating, instead of just practicing on the real you, right? This is another one of my favorite innovations within 3D printing. So I mentioned before we have a lot of rural patients. We're highly rural, and especially for me in the Northwest, in the Pacific Northwest, 29% of our patients are rural. Seattle, we take care of our catchment zone, encompasses Alaska, all of Washington, parts of Idaho and Montana. So this is a patient that lives up in a rural area within Alaska. So for him to get any routine care where he needs to see a specialist, he has to take two plane rides to get to the doctor. So, you know, it makes your commute to the doctor look not so bad when you think about it. And he was an lower extremity amputee. So he had an amputation on the right side, and he had a prosthetic. So he favored the left side. And unfortunately, by walking mainly on that left side, he ended up damaging his hip. He had to have a total hip replacement. So this is him on the left. And then something happened that can happen, but it's non-ideal. Is he started to form all this extra bone formation. So if you look at that and you're thinking, that doesn't look right, that doesn't look like a hip. It almost looks like there's melted wax from a candle all over that. That's heterotopic bone formation. And it can be painful and it can cause problems. And so the decision point is, should the surgeon go in and operate and remove that? And you know, it's not without risk. And so his surgeon up in Alaska was not comfortable doing this. And so he said, let's send you down to Seattle and see if we should do this or not. So normal case scenario, he gets on a plane, right? He flies to, so let's say Juneau in Alaska, then flies down to Seattle. He goes and sees the surgeon. They have a preoperative appointment. Then he gets on the plane. He flies back home, right? Then he comes for the surgery. He's going to get on the plane again, fly back down, gets the surgery. He's going to have to stay in Seattle for a while, fly back home. Well, we said, well, that's a lot of flying. What if we could have him see him? So instead of having him leave Alaska, they just had a CT scan done there. They sent the images to us. We printed it in Seattle. We gave it to the surgeon in Seattle. And we also printed one and sent it up to Alaska for his physician there and for the patient. And then they were all three able to talk. Again, he's not left home. He's not left his support system. And that's very important. And the expert in Seattle looked at this and said, you know what? No way. This is a really bad idea. That's a lot of bone. It's touching very important vessels. It carries significant risk of mortality. We should not do this. And that was a very definitive answer that he gave. And he could not have given that answer if he had just seen him in the pre-op evaluation or looked at the imaging, because it wasn't apparent from the imaging. So what would have happened is he would have flown down, the patient, flown back up, flown down, been anesthetized, gone into surgery. He would have been opened up. They would start to operate, and they would have looked at him and been like, ooh, bad idea, close him back up. Then he would have recovered and gone home. So we saved him not only 2 trips, but an unnecessary operation. A great use of the technology. We're also thinking forward to the next best things. Can we innovate within the innovation? These are various aortas and heart valves where we're thinking about the next treatments, minimally invasive cardiac surgeries. Across VA, more and more centers are offering this treatment. So minimally invasive replacement of aortic valves, mitral valves. It's quite amazing how they can do this. Go through a vessel instead of cracking open the chest. Put a valve in a way that you could post-operatively get up and be moving around very soon. But the problem is you never open the chest, so you never see the actual heart. So you have to figure out all the sizing and all of the, various components of that from imaging. But this is allowing us now to just print the actual patient and try it out. There's nothing like just trying something on for size. If you online shop, it's hit or miss. They tell you what the sizes are. Yeah, you should have this with that. I don't know about you, but it's seldom what I expect. So it's always best to try it on. So this is something that we're doing as well. So that's the first part, right? So we have a tech innovation, or invention, actually. We have brought it into our hospitals. We are trying to put it in the hands of as many different frontline staff as possible. We want them to think about the ideas, the concepts, try it out, but that is only the start of innovation, which unfortunately is hard work and a long journey and can be arduous at times. So what are we doing within VA to push this forward next? And this is probably the most important thing that we can do, is we're thinking about all the infrastructure and all the steps behind this that make it happen. How do we do point-of-care manufacturing? That's what we're calling it. So 3D printing is just an additive manufacturing technology, a way of making things. How do we do that in the hospital? We have to think about our processes. We have to validate those processes. We have to think about what personalization means and how we're going to do it. We have to think really hard about regulatory considerations. What does this mean from a regulatory perspective? And so, again, VA is the largest healthcare organization in the country. We have access to resources and staff that allow us to do this work. And we're going to be partnering with as many people as possible, both internal to government and external to government, to do this. And that's really important too, because what we'd like to do at the end of the day is not only provide this for our 9 million veterans, but then be able to hand off the lessons learned, the capabilities, the technology out to the private sector and beyond, so that all patients can benefit from this. So what's next? What's on the horizon? Bespoke implants and prosthetics we're very interested in. How do we make smarter prosthetics? We can embed sensors. Can we make materials that change with you during the day? If you're swelling up at the end of the day, can the material change with you? Can it report back to us? Smart technology. Tell the doctor, hey, like our patient with the hip, the weight distribution is not good. Where you're wearing on that joint. You need to change that now before something bad happens. One of my personal favorites, this new era of telehealth. VA was a leader in telehealth, but can we imagine the next iteration? How we bring patients closer to their providers without them leaving their home and their support. And then 3D printing of tissues, bioprinting, that could one day maybe address global shortage in donor organs. Now, I like the slide from earlier this morning where we were talking about the New York Times saying, flying is 1,000,000 years away, and we see in the Wright brothers' diary, I started today. Well, we're starting today in VA, and this doesn't look like much, right? This is an Eppendorf tube, and it's got something that maybe looks like a little Rice Krispie treat in here, but this is actually bioprinted bone. This is our first iteration, and we did this about 6 months ago, and we are much, much further along already. And why are we trying to print bone? Because there's a critical need for our patients, right? So we'll see where we go, but that's on the horizon. So we kind of started this talk with looking back to Dr. Rankin and 3D X-rays and what that means. And I asked that question, is medical 3D printing destined to become as commonplace as the X-ray? I love this question. I don't know what the answer is, but I think it should. And I think that means that we have the hard work to do to bring this to the public and make it really happen. And that's what we want to do in VA. So thank you. And I might have gone a little long. It looks like I have 3 minutes, or no minutes. Yeah? Oh, well, I can answer questions then. Yes?
Good morning.
Morning.
What happened to the veteran in Alaska? Good morning. Yeah. What happened to the veteran in Alaska that you talked about? Were you all able to do anything to help him?
Yes, and I think this is a fantastic question. So what happened with that patient? Because sometimes, when I started 3D printing, I always thought it was to get to the surgery, to convince the surgeon to do something that was difficult, and then I learned that sometimes we convince the surgeon not to do something. But a few important things happen, I think. First of all, it takes that off the table. And so surgery is often the answer. An answer, not the answer, but the answer we jump to first. So what happened with that is they took that off the table and they started to think about other things. What can we do? Maybe we should address that prosthetic. Maybe, we can get a better fit so he's not favoring that left side so much. Maybe there's some physical therapy. Maybe there's some, modulations we could do with pain. Maybe it wasn't that bad, and we just tried to fix it because it looked bad. So he's doing well, but the short and the long of it is that allowed them to open their eyes again and rethink what the treatment plan was going to be. So.
And what was the treatment plan?
So in that case, it was, again, just working on that prosthetic, seeing if we could get a better fit in physical therapy, yeah. Yes? Oh.
Yeah, thanks for your talk.
Yeah.
And you're talking about these innovations, you talk about you have now the 3D printers in 25 different locations. The thing I think about is workforce training and the ability to, you talk about the cultural piece and the treating patient piece of it, but the actual use of the technology and thinking about it in different ways. How are you addressing that?
I'm so glad you brought that up. So workforce development. There are not a lot of people that can do this work right now. So who can do medical 3D printing? You need to understand engineering. You need to understand anatomy. You have to be able to talk to doctors and surgeons, and depending on who you are, that means you might have to have some patience, right? So there are a handful of people out there right now that can do this, but we are very critically aware of that need. I'm critically aware because I'm tired of making all these. I want help. But just kidding, I like making them. But so we are joining forces. So again, this is where collaborations come in. So within VA, we're looking to our partners in education to help us think about how do we develop curricula for this. We talk actively with members of societies such as, Society for Manufacturing Engineers or the American Society of Mechanical Engineers, who are very adept at the engineering aspects, to see how might we come together and bring some of the medical into that. We're talking with the DoD about how they're going to train. And so our goal is in the next few years to come up with an initial curriculum for this. And again, we want to leverage the fact that we are also a large academic training organization with our academic affiliates and have them coming in too. So we're working on it. Oh, we're done. Thank you.